Okay, great. Let's unpack this. So we're kicking things off with meniscal tears. I mean, I'm sure you see these walking through your door pretty regularly.
Yeah.
It's an incredibly common reason for knee surgery, isn't it?
Oh, it absolutely is. Meniscal tears are the most frequent indication for knee surgery. They happen both from acute incidents, like a sudden twisting injury.
Right, sports injury or something.
Exactly, but also increasingly as a degenerative condition, particularly in your older patients.
Okay, so when a patient comes in, whether they've had a specific injury or it's just, wear and tear over time, what are they typically telling you? What are those sort of classic symptoms that should immediately make a GP think meniscus?
Well, patients usually describe pain. It's often localized, either medial or lateral side of the knee. But what's often a bit of a giveaway are those mechanical symptoms.
Ah, the locking and clicking.
Precisely. They'll talk about their knee locking up or maybe a distinct clicking sound, especially when they do things like squatting.
And when you're doing your physical examination, what's the one sign that really has the highest sensitivity? The one thing you should definitely check for?
The most sensitive physical exam finding you'll likely encounter is joint line tenderness. Simple as that.
So just palpating along the joint line?
Yeah, if you're palpating along that line and the patient says, ouch, that's a very strong indicator. The McMurray's test is also commonly done.
Right.
A positive result there, that's a palpable pop or click, plus pain that can specifically point towards a medial meniscus tear. You might also find some swelling, maybe an effusion in the knee, but that's a bit less specific.
Got it. So you've got your clinical suspicion up. What's the diagnostic approach from there, particularly with imaging? Do you just immediately jump to an MRI?
Not always, no. For younger patients with acute injuries, x-rays are usually normal. They're mainly useful for ruling out other bony issues, fractures, that kind of thing.
Okay.
However, to actually confirm a meniscal tear, MRI is really the most sensitive diagnostic test.
And what are you looking for in that MRI report?
You're looking for a linear high signal that extends completely through the meniscus to either the superior or inferior surface. That's what they call an MRI grade 3 signal.
Grade 3. Okay.
And here's a useful tip. If you see a parameniscal cyst, basically a little fluid-filled sac near the meniscus, that also strongly suggests there's an underlying tear.
Right, okay. So you've confirmed the tear on MRI. Now, what's the initial approach to management? I know many GPs are keen to avoid immediate surgical referral if there's a good non-operative path. Is surgery always the answer?
That's such a crucial point for general practice, and it's probably a significant shift in thinking for many. For degenerative tears specifically, non-operative treatment is actually the first line.
Really, first line.
First line. This involves things like, appropriate rest, maybe some NSAIDs, and definitely a structured rehabilitation program. Physical therapy.
And how effective is that?
What's truly interesting is that this conservative approach often leads to significant improvement in knee function. The evidence suggests it's actually considered non-inferior to surgery for these degenerative cases.
Non-inferior. So basically as good as surgery, outcomes-wise.
Pretty much, yeah. It means we can often achieve comparable results without the risks and recovery time of a procedure.
Wow, that's a massive takeaway for our listeners. For those degenerative meniscal tears, the first line is not surgery, and it's effectively as good. So when do we then need to refer to an orthopedic specialist for potential surgery?
Okay, so referral for operative treatment is indicated when those non-operative measures fail to provide relief, or for specific types of tears that are just unlikely to heal conservatively.
Like what types?
Well, there are two main surgical approaches. A partial meniscectomy, basically trimming out the torn part, is typically done for tears that aren't suitable for repair. Think very complex tears, or those degenerative ones that haven't responded to non-op care.
Okay.
On the other hand, a meniscal repair, stitching it back together, is generally preferred for specific types. Things like peripheral tears in the red zone, that's the vascularized outer part.
Where it has a blood supply to heal.
Exactly. Or for vertical longitudinal tears, bucket handle tears, or root tears, particularly in younger patients where preserving the meniscus is really key.
Makes sense.
And it's also worth noting, healing rates for repairs are often significantly higher when they're performed at the same time as an ACL reconstruction.
Ah, okay. Good synergy there. And just to close the loop on historical context, wasn't total meniscectomy just taking the whole thing out once common?
Yes, but thankfully that's now mainly of historical interest. We understand much better now that removing the entire meniscus is strongly associated with significant arthritic changes down the line. So it's been largely replaced by these more conservative approaches like partial meniscectomy or repair.